more than any other class that I've ever had. Like at the end of every month, YouTube gives me stats and I can see like how many times each video has been watched and all of that. And you guys watch more videos than any other class has. I don't know what that means or anything else, but I'm glad that you all are, at least some of you are getting some things out of this. So I think we can get through everything today. If I can cover more than like 5 slides. But we talked about this last week. We talked about this on Friday. Okay. But I'm just you can have the slide. It's going to be stated. Aerobic training, any kind of training, to be honest, leads to the conversion of type 2X fibers to type 2A. Okay. There's no other changes in fiber type that happen. There's no 2s to 1s. There's no 1s to 2s. It's only 2X to 2A. Okay. And remember when we saw all the changes in PGC1 alpha, that you get these ginormous changes in PGC1 alpha expression in type 2A fibers in response to training. And so that's why, as I mentioned on Friday, I can make every person a much, much better distance athlete. Much better. Because no matter how many type 2 fibers you have, we can dramatically increase mitochondrial content as they go to 2As. Okay. And that has very, very profound effects on your ability to use oxygen, your ability to use fat as a substrate, your ability to not make lactic acid. And that's going to all stave off fatigue. All right. So, big one thing. Why would that be important? We kind of buried the lead on that one last week. Okay. So, again, I brought this up, but we're gonna sort of walk our way through all of this when I get ahead of myself, like on Friday. The other big thing that happens as we train is the more well aerobically trained you are at any amount of food that you eat, no matter what that sort of substrate is, you're going to derive a greater proportion of your energy from fat. Okay. So run more, bike more, get to eat more Chick-fil-A. Okay. That's the way that I always approach this. Or pizza or whatever it is that is your particular kind of thing. Okay. Doritos, whatever. Okay. At rest and during exercise, you derive a greater proportion of your energy from fat. So you can just sit around and do nothing and you're going to derive more energy from fat. Okay. What this does, okay, is it spares muscle glycogen. Because you're using fat, maybe not at rest, but during exercise, because we use more fat, our RAR is lower at any given exercise intensity. That means we're using less blood glucose, we're using less muscle glycogen, and that limits fatigue, right? That limits central fatigue. At any given intensity, at any given speed or work rate, oxygen consumption does not change because energy demand is equal. Okay? Trained versus untrained, as long as you weigh the same, the energy cost of you running 7 miles an hour is identical. Okay? It's identical. But RAR is going to be lower at any rate, despite VO2 being the same, because we're using more fat. That leads to making less lactate. It leads to sparing plasma glucose, sparing muscle glycogen. And so we get less fatigue. This is one of the big adaptations. This happens because we break down fat in mitochondria. We have more mitochondria, therefore there's a greater chance for us to use any fat that those mitochondria are exposed to. It's just simply biochemistry. There's more of one, so we use more of the other. And that's how that's gonna manifest. Okay. More Krebs cycle enzymes. And so remember also that when we use more fat, it inhibits our use of carbohydrates. That's going to be good. Additionally, okay, as you become more trained, any given exercise intensity is less stressful. And by stressful, I mean less sympathetic nervous system response. There's less epinephrine, less norepinephrine that's going to be released, okay? That decreases the breakdown of glycogen and it decreases lactate formation, okay? It keeps PFK from getting activated, to quite the same extent, and it keeps especially muscle and liver glycogen from being broken down. Okay, so because it's less stressful, there's less here, and then we have lower lactate right in the blood, results in less inhibition of fat breakdown. The lactate and the hydrogen inhibits the fat, so there's this kind of feed forward mechanism that as we use more fat, you use less carbs, you make less lactate, which lets you to continue to use more fat. Okay, so I'm not going to get into too much with you guys that you have to know all of the particulars here, but I do want you to know kind of the very, very basics on all of this. Okay, the very basics. So more mitochondria, more fat use. Very, very powerful adaptation to training. Okay. So how do all of these changes lead to an increase in performance? Because that's the big take home, right? We change fiber type, we change mitochondria, we change capillaries. Like we're doing these things, but how does that make you? How does that manifest from a performance standpoint? You can run faster or run farther or some combination of those two things. Okay. Well, during long duration exercise, there's less fatigue. There's less lactic acid that you make, so there's less peripheral and central fatigue from lactic acid. And because we spare muscle glycogen and we spare plasma glucose, there's going to be less central fatigue, right? And so we're going to spare those because we're using more fat. That's the big thing that's going to be there. It's really increased fat use, less lactic acid, less glucose and glycogen use. So it's the combination of those kind of four things together that gets us where I can be at a higher VO2 or a higher sort of speed, and I make less metabolic byproducts. I use less glycogen, I use less glucose, so I'm going to become during short duration exercise. This is kind of a weird one. Aerobic training doesn't help that much during short duration exercise. Big thing that it does with short duration exercise is it leads us to recover faster in between repeated bouts. Do a sprint, rest, you recover faster when you're more trained. More mitochondria, you shorten epoch. Okay, you shorten epoch. But there's a little bit of evidence, and when I say short, I don't really mean sprint. I mean things that are going to last just a couple of minutes. As you train a bunch, especially if you do a little bit of higher intensity training, you learn to tolerate lactic acid to a better extent. And by tolerate, what I mean is you are accustomed to what it feels like to be uncomfortable. Okay. Your muscles burn, things of that nature happen, and you become more accustomed to that. You're more willing to tolerate that uncomfortableness. And we do see that, not in everybody, but in some people. And then there's going to be a little bit of an increase in your ability to buffer hydrogen ions from how we store CO2. Okay, for how we store CO2. We have an interesting idea for a study to do in the lab that we've never done, where we wanted to take people and have them do high intensity interval training for 6 or 8 weeks. So you come in and you do sort of 30-second all-out bouts of exercise, rest for a couple of minutes, do it again, do about 5 of those 3 times a week, and train over time. It's incredibly uncomfortable. It's incredibly awful. We want to do that and then test how much pain you can tolerate before and after, and then compare with people that are doing sort of non-painful exercise that would increase their fitness the same. We think that something about I'm exposed to pain, I'm exposed to things being uncomfortable, makes it to where you're more willing to kind of do that again. You're less scared about it. You catastrophize less. You're willing to tolerate that more going forward. Okay. All right. I think I told you all this as well about maybe last Wednesday when we talked about the pulmonary adaptations. When we look in the pulmonary system, in response to aerobic training, there's very, very little adaptations that take place. Very, very few. Okay, at rest, no change. Whether you're trained or untrained, your breathing rate and breathing depth is basically the same while you're just sitting there. Nothing's going to change. Nothing's going to be different. Okay? During submaximal exercise, below lactate threshold, also basically the same. Basically the same. Okay. When you get above lactate or above ventilatory threshold, you get a little bit better at buffering. So ventilation tends to be just a little bit lower at any given absolute work rate or percentage of VO2 than it was before. Okay. You're better at buffering, you're making a little bit less. Okay. This is likely due to decreased lactic acid production and increases in buffering. At maximal exercise, and this is not an adaptation, okay, but because your VO2 max goes up, at the end of that max test, if we measure your maximal ventilation, it's going to be high. Okay, it's going to be high. But that's probably not a training adaptation. It's a consequence of you're more fit, therefore you can use more oxygen and you can reach a higher portion of your capacity to ventilate. Most of you in here right now have a greater capacity to ventilate than your metabolic systems will allow you to reach. Okay? There's a ceiling on breathing rate and breathing depth. And most of you guys, when we do a max test, you get, within maybe 20% of that. Okay. Some of you, if you're really, really fit, can get pretty close, but most of it, it's not that anything up here changes. It's just that everything else changes and it allows you to continue exercising and push so you can get up closer to what that kind of physiological maximum ventilation is going to be. But nothing changes in your lungs. Nothing really changes in your diaphragm. You guys are not so unfit that your diaphragm is unfit or anything like that. And it's just that everything else changes and lets you get closer to that kind of top end capacity. So when we measure it, it looks like it's gone up, but it really hasn't. Does that make sense, guys? Do you kind of understand that concept and that idea? I need to see some nods. We're working ourselves towards squats really, really, really quickly in the midst of things here. Okay. Okay. Now, to a system where there are a lot of changes. Okay. Where there are a lot of changes. And you can trace how these changes relate back to an increase in VO2 max, relate back to an increase in performance, back to the Fick equation. Back to the Fick equation. Okay. So we're going to hit cardiovascular adaptations. The first one that happens almost immediately is that blood volume increases. Okay. Blood volume increases. Total volume goes up with training. Initially, you get an increase in plasma volume. And then trailing that increase in plasma volume is going to be an increase in red blood cell count. And I'll show you guys what that looks like in just a second. Okay. But run today, bike today, elliptical today. And because of the changes in aldosterone and antidiuretic hormone, you're going to retain a little bit of extra water. You're going to drink a little bit of extra water, probably, okay, over the next 24 hours. And you're going to have this, it's very small, but it is measurable, increase in plasma volume tomorrow and the day after, okay? And there have been studies that have shown that that small increase in blood volume, that small increase in plasma volume is enough to make your VO2 max go up tomorrow, okay? It's right at just about the error of measurement in our metabolic carts. So, think like 1 ml per kg per minute or something like that. Like we're right at the error of measure, but they've done studies and they can see it very, very quickly. Okay. So plasma up first, volume gets greater, but because of that, hematocrit percentage drops. And then a couple of weeks trailing that increase, we're going to make more red blood cells and we'll see a hematocrit increase basically back up to where your kind of regular baseline levels are. So if you're at 40% hematocrit now, you start training, your hematocrit percentage is going to dip maybe into the high 30s for a couple of weeks, and then the red blood cells will catch up. Takes them a couple of weeks, and you'll get back to like that 40% value. Okay. This is due to a thing. I don't know where I saw this term, but I like it because I feel like it explains what's happening. Okay. And so this person that I cannot remember termed this a persistent acute effect. Okay. What does persistent mean? Constant, right? Your neighbor is persistently poking you when you come to class, right? Constant all the time, right? Over and over and over again. What does acute mean?
Short term.
Short term, right? So it's this constant short-term effect. Run today, get a bit of an expansion tomorrow and the day after. If you don't run again or bike again, after about 48 hours, it goes away. Okay, it's an acute effect. But if I run tomorrow and the day after and the day after, or maybe I only take one day off in between bouts, then I'm always in that window where I'm stimulating that acute effect. Okay, does that make sense, guys? Y'all understand? Like I run and I get a little bit of an increase. I can take tomorrow off, but then I run on Wednesday. I'm still in that window of that acute effect. Now I stimulate it again. And I got another 48 hours and another and another. As long as I continue to train, I'm going to push that acute effect. As soon as I stop, it begins to go away. Okay? It begins to go away. So this persistent acute effect is driven by ADH and aldosterone, which go up with exercise, especially if it's exercise where you raise your core temp enough that you're going to sweat some. And we overcompensate after by drinking more and making less urine, losing less water. Okay? It goes away very, very quickly as soon as you stop. Okay? This is a persistent acute effect. Right? That's going to make your blood volume increase. Okay. Some data. Why is blood volume important? Well, here's VO2 max on the y-axis. Here is total blood volume, okay, on the X. And this is every dot represents a person. And you can see as we go across all of this that as VO2 max goes up, blood volume goes up. There's a relatively linear, or at the very least, sort of a positively accelerating kind of quadratic equation that would explain that greater blood volume means higher VO2 max. Use the Fick equation and tell me why blood volume goes up, VO2 max goes up. Which piece of Fick is affected by blood volume?
Stroke volume.
Who said stroke volume? Fear says stroke volume. Do you all agree? Could it be heart rate? Could it be a VO2 difference? Could it be extraction?
Difference. Also, you have more. Good. So you can catch more oxygen.
Could catch more oxygen. Okay. Maybe. Veer, why would increasing blood volume increase stroke volume?
More venous return.
More venous return. Absolutely. Okay. It's primarily driven by stroke volume initially. And then, as Tyler said, as the red cells catch up, then we're going to get some of both. Okay. But the big deal for like tomorrow, run today, more plasma, VO2 max goes up tomorrow, is there's more fluid for more venous return. Okay. Again, that's why all those things that we went through in the cardiovascular system are so important. If you understand those, you can understand how these adaptations drive, how they drive an increase. Okay. We know that blood volume will go up maybe 20 to 25% with chronic training. Okay. So if you're at 4 liters of blood now, which is about where a lot of you ladies are going to be, okay, it may go up to 5. Guys, if y'all are at 5 or 5.5, it's going to go up to maybe 6.5, closer to 7 in some instances. Okay. So very large increases, which means stroke volume can go up, right? Red cells eventually will go up. What this graph is trying to depict, okay, on the y-axis, this is the percent delta, or the percent change, okay? And then on the x-axis, it's the number of days that you've been physically active. So this is the number of days that you're training. Here is 0. Here's where we start. And the black dots represent blood volume. The open circles represent plasma volume, and then the open squares represent red blood cells. And I appreciate that I told you right here it would go up 20 to 25%, And in this graph, it's going up about 10%. Okay, that was just what happened in this group of participants. But I love this graph because it shows there's this big initial spike in plasma volume, and then there's this lag of about 2 to 3 weeks before red blood cells begin to catch up. And so don't worry so much about the individual numbers on this graph. I just like the fact that it shows that plasma goes up immediately and red cells lag a couple of weeks behind, and they eventually sort of even themselves back out so that our hematocrit percentage stays relatively the same. And that's the normal response. Okay, that's the normal response. If you want to make your hematocrit percentage go up, you have to go to altitude. Okay, or you have to sleep in a low oxygen tent, which people will do, athletes will do. Okay, but guess what? How do we make you go to altitude? You guys know the first thing that happens when you go to altitude that the body does to try to make you have a higher hematocrit percentage immediately? Don't breathe. I mean, you may breathe more, but that's driven by that there's more CO2. What's the first thing we do here when we train? What's the first thing that goes up? Plasma volume goes up first, okay, which lowers hematocrit percentage. So if I wanted to raise my hematocrit percentage, I decrease plasma volume. You go to altitude, and the first response of the body is to dehydrate itself a little bit. And by dehydrating, your blood volume actually does the opposite. It goes down because you urinate out more plasma. You make more urine, you dehydrate yourself, but the consequence is I'm not 40% red blood cells. Now I'm 45% red blood cells. And so the carrying capacity of what I have is higher, which kind of counteracts a little bit of that. It's an interesting thing. At altitude for several weeks, then you're going to begin to drive increases in red cells. Okay? That's why living at high altitude or sleeping at high altitude stimulates the red cells, but then come back down, train at lower altitude, you can keep some of the plasma volume stuff up and you can get the best of both worlds. So, like,
Might be that much. But because when you decrease plasma, the percentage of red blood cells goes up.
Yes.
Does the number go up? So why is it just the percentage?
it's just the percentage.
Then how does that like increase carrying capacity if they're still not the same amount?
Because we calculate carrying capacity as the percentage. And that's due to the biochemistry of diffusion, basically, that it's the percentage of the fluid that is red cells. There's more oxygen per volume of fluid because of that, and that makes that kind of partial pressure of that gradient higher when we do all of that. I'm with you that it seems counterintuitive. There's the same red cells, there's the same amount of oxygen that there was before, but it changes that partial pressure, which is calculated as the percentage of the volume. And that's what drives the diffusion gradient. It's a really good question. Okay. Second things that are going to change. AVO2 difference, or at least max AVO2 difference. So max ability to extract oxygen goes up. Okay. Fit or unfit, run right now, your AVO2 difference is the same. VO2 is the same, AVO2 difference is the same, nothing changes. The only place we see differences in AVO2 difference is as we get over our previous high VO2. Okay, VO2 max was here, your new VO2 max is up here that's higher. The only place you're going to see a widening of AVO2 difference is when we get above our old max. Okay. That is primarily driven by increased extraction because of increased capillaries and increased mitochondria. Right? Increased capillaries, increased mitochondria. More blood to the muscle because of the capillaries. Slower blood flow around that muscle when it gets there because of the capillaries. And more mitochondria. Having more mitochondria weirdly keeps the partial pressure of oxygen inside of a muscle cell low because it uses up all the oxygen that's there. And by keeping that partial pressure low, it keeps the gradient, the difference between inside the cell and inside the capillary as big as it can be, which leads to pulling the oxygen out. Okay. So blood volume increases, that gets us from the stroke volume side primarily in the Fick equation. And then the mitochondria and capillaries help us extract more, so that makes the AVO2 difference go up. So now we've changed two pieces of the Fick equation to make VO2 max go up. Okay, two pieces. Does heart rate change? We'll let you think about that. We'll get to it, okay? If we look at blood pressure, if you're not hypertensive, there's no training adaptation to blood pressure. Your blood pressure stays the same. The response during exercise is basically the same. You're going to get the same, increase in systolic and diastolic is going to stay relatively similar. However, if you are hypertensive, and basically all of us before y'all are my age, they're going to keep changing where they outline the things. We're all going to be hypertensive. At some point, they're going to decide that like a systolic pressure of like 105 is pre-hypertensive. When I started doing all of this 25 years ago, like you had to be over like 120 was normal, but you had to basically be in like 135 to be considered pre-hypertensive. 140 was the cut point. Now, right, like 130 is basically hypertensive and 121 is pre-hypertensive. At some point, they're going to figure out like, we're all going to be hypertensive at some point, right? That's just the way to do this. We're all going to be hypertensive. Even my father, the bionic man, is now, they're like, he told him he's pre-hypertensive. He's all upset. Well, Dad, your blood pressure is like 125. Also, you're, 78 years old, and like this is just a thing that happens to all of us in the midst of this. Okay, but training, unless you're hypertensive, doesn't change things. If you're hypertensive, okay, we see maybe a 5 to 8 to maybe 10 millimeter drop in systolic pressure response to training. Okay, a little bit, not a huge amount, but a little bit of a drop. Okay, but a little bit of a drop. I have them in here. If you really want to make them go down, you need these. You need the beta blockers. Yes, I just carry them around. So, in case I have a panic attack, then they won't give me Xanax anymore. I have to have this. So, which is a good thing. Xanax is very, very addictive. In the midst of this, okay? The mechanism for the decrease in blood pressure is not fully understood. It's probably multifaceted. Okay. It's probably multifaceted. And part of it may be due to something that we're going to call arteriogenesis. Okay. Arteriogenesis, and this happens whether you have high blood pressure or not. Okay. Arteriogenesis is remodeling of arteries and arterioles, but especially arteries, to be bigger. When I was a master's student, we took an ultrasound unit, and we would image people's femoral arteries, we would image people's brachial arteries. So it's like, like the ultrasound you use to see a baby or something. Dr. Paddock has one, Dr. Kellowan has one. We have one in my lab, but it's old and crappy, and you just use it to look at muscle, like kind of muscle size and those sorts of things. But you couldn't get an arterial image. And when we would test people, you could always tell very, very clearly when you did femoral artery imaging who was in shape and who wasn't, who was fit, who was an aerobic person. Because per their body size, if you're really fit, their femoral artery would just be like just giant pipe. Okay. And if you would test for my master's thesis, I tested women that had chronic fatigue syndrome. They were very, very, very sedentary. Okay. They could not exercise. And we would image them, and they would have femoral arteries that were like half the size of trained people. And the reason that was the case is this idea of arteriogenesis. Okay. It's sometimes called vascular remodeling, but what it is we increase the lumen size. So you increase the size, right, of the artery and arteriole, you increase the diameter, and you decrease the wall thickness. Okay. So I love, again, the way these graphs look. Okay. You're not responsible to know what's going on in each one of these, but I just like what it illustrates. What you see here, okay, on the y-axis is change in femoral artery diameter. So it's a percent change. You have some baseline that is here. These are kind of normal, average, sedentary people. You do 8 weeks of training and the femoral artery gets bigger, 12 weeks, bigger still, endurance athletes, really fucking big. Okay, great big pipes. Okay, then they took data. This is from a review article. So these are all different studies that did this. They put people in a cast for a week and it goes down 5%. 4 weeks of unilateral lower limb suspension to mimic space flight, 4 weeks of bed rest, 7 weeks of bed rest, 9 weeks of bed rest. Okay. They don't have data from the astronauts that go to the space station that go in space flight in here, but the same thing happens 3 weeks after a spinal cord injury, years after a spinal cord injury, like 30% smaller. Okay. And so what this shows just is the spectrum that how physically active you are is very much related to the size of your femoral artery diameter. Okay. Here's the same sort of thing. Femoral wall thickness. Okay. And so it's the exact opposite. The sort of less active you are, the thicker the wall, the more active you are, the thinner the wall. Much like what we see in left ventricle wall thickness, having a thinner wall means it's more elastic. Okay, thinner wall means more elastic, and when those pressure waves come through, there's more ability to expand and go back to where it needs to be. You can absorb all of that stuff much easier. So this is arteriogenesis. Okay, arteriogenesis. And you may say, well, Dr. Black, what is it about exercise that drives arteriogenesis? What's the signal that's going on? We think it's two things, okay? It's stretch of those arteries and those arterioles from the increasing the pulse wave from the increase in blood pressure. So if I had you guys get up and do squats, you do some squats, your blood pressure goes up immediately. As the blood, every beat goes through the femoral artery, it tries to push out in the artery and it stretches. Okay. So we think that's one of the signals. The other signal is shear stress from an increase in blood velocity, which happens during exercise as well. Remember, the shear stress leads to the release of nitric oxide, which leads to vasodilation. And that's in essence what we're doing with the remodeling is we're just getting vasodilation. These things signal through something called the endothelial-derived nitric oxide synthase, or ENOS, something called MCP1, and then one of my favorite ones, which is called vascular endothelial-derived growth factor, or VEGF. Okay, you don't have to know these names, but I want you to appreciate and have seen them at least, that we stretch, right, with the blood pressure increase. We shear with the increase in blood velocity during exercise, and that signals sort of a cascade of signals that tells that artery to remodel and essentially vasodilate permanently. Okay? And it still has the capacity to vasodilate once it's remodeled, but that's what we're doing. By vasodilating, pressure falls inside, blood velocity falls, and those are both good positive adaptations. Okay? All right, we already talked about capillaries, but capillary increase is actually called angiogenesis. So I want you guys to make sure that you get these two things correct. Okay, arteriogenesis is making the arteries we have wider. Angiogenesis is new capillaries or new blood vessels. You get some angiogenesis, especially in the coronary arteries. You get more branches. Very, very positive adaptation because there's more places for blood to go. Okay, more places for blood to go. Capillary increase seems to be fiber type specific. Okay, and it's stimulated by many of the same sorts of things: shear stress through the capillaries, nitric oxide release upstream, VEGF, changes in pressure. Okay? So essentially, sending more blood through the arteries and arterioles and capillaries that we have leads to positive adaptation. Bigger arteries, more capillaries. Okay? bigger pipe, right, for the plumbing to go through, more small little pipes to send it out to the muscles so that we can get it there. That decreases diffusion distance, it slows blood flow like we've already talked about, and it increases our ability to remove CO2 and lactic acid. I love this graph too. This was published in a review article that was published in 2011. These data are actually from the 1960s, okay? Or maybe the early 70s, but it's the number of capillaries per fiber, or the capillary to fiber ratio. So you take a muscle biopsy, you pull out the muscle, you dissect it down, you see the individual muscle fibers, and you count the number of capillaries that are leading to an individual fiber. So that's how we get that capillary to fiber ratio. That capillary to fiber ratio tends to be higher with slow twitch fibers, higher in 2A versus 2X. And then they've graphed that against VO2 max. High VO2 max, 80 ml/kg per minute. Relatively kind of lower-ish, or what we would call kind of normal these days, 35, 36. As capillary density goes up, VO2 max goes up. Capillary density drives increases in extraction, which is going to drive up a VO2 difference, which can help drive this. Okay. So more capillaries combined with more mitochondria means an increase in a VO2 difference. This is angiogenesis, though. Angiogenesis, arteriogenesis, bigger arteries. Okay. Okay, I ask you guys, what happens with heart rate? Weird things happen with heart rate. It's not what you think. Okay. The primary adaptation in heart rate when we exercise a bunch is resting heart rate falls. Okay. Resting heart rate falls. There's no change in max. No change in max. Your age predicted max heart rate stays basically the same. Some of you, if you're really highly trained, are even less likely to be able to reach your age predicted max heart rate. But resting heart rate may fall. Maybe 10, 15, 20 beats per minute at rest. Some of this is because of increased parasympathetic input. And as stroke volume increases because the left ventricle hypertrophies, which we're going to talk about, okay? As stroke volume goes up, you can maintain cardiac output with a lower heart rate. If you need 5 liters per minute of cardiac output at rest, if my stroke volume goes up, my heart rate can go down and still maintain that 5 liters per minute. So that tends to be what happens. The implication of this is that because it's lower, the heart uses less energy, it becomes more efficient at pumping blood around. Okay. The other piece of this is because it starts lower, it's likely to be a little bit lower at any given exercise rate. Okay, at any given exercise rate. That's why we have to calculate heart rate reserve, which I know makes all of you guys want to throw things at. Right, we got to pick out your target heart rate based upon resting and max, as opposed to just a percentage of max heart rate. Okay. As I said, we've already talked about partially because of venous return, but stroke volume also goes up with training. One of the big things is the plasma volume and venous return. The other piece is that left ventricular size goes up. We get cardiac hypertrophy, okay, from cardiac hypertrophy. So there's an increased lumen or an increased volume inside the ventricle, which means we can put more of this increased blood volume that we have into it. It also becomes stronger, right? It can stretch more, so we can get things out that way. As heart rate decreases, there's an increase in filling time. So we have more venous return, we have longer to put the venous return in, and we have a larger space in which to put it. All of those are going to work together to make stroke volume go up. Now, I know that those of you all that were in Dr. Paddock's class heard about this the other day, but I'm going to try to finish off by talking about that not all cardiac hypertrophy is the same. Okay? Not all cardiac hypertrophy is the same. When you aerobically train, you force more blood back in and it stretches the ventricle to a greater extent. That stretching functions like an eccentric contraction, a stretching or lengthening contraction. And that gets what we call eccentric, right, or volume overload hypertrophy. With training, the ventricular lumen gets bigger and the walls stay thin. Okay, the walls stay thin. People that have high blood pressure have to contract the left ventricle more forcefully to overcome the afterload effect in the aorta, to overcome aortic pressure. And so that means it has to squeeze more forcefully. That's a concentric contraction. And so when that happens, when you concentrically squeeze more, okay, you get thickening of the ventricular walls. You get what we would think of as regular hypertrophy in skeletal muscle, or concentric or pressure overload hypertrophy. You guys heard of something called hypertrophic cardiomyopathy? Anybody heard of hypertrophic cardiomyopathy? It's very common in athletes, people that have an enlarged heart. Every year you'll see someone who's like a marathon runner and they will go into cardiac arrest running a marathon. They're in super great shape. They're very, very healthy, and they'll figure out that they had hypertrophic cardiomyopathy. That's a genetic condition where you just have an enlarged heart. You have all of these, and it leads to an increased chance of heart attack and having disruption in the cardiac conduction system. The same thing happens in people that have high blood pressure. As the heart enlarges from that concentric hypertrophy, then you get a greater chance or an increase in chance that the cardiac conduction system can get messed up. So what we want with exercise is eccentric hypertrophy. It stretches, we get a bigger left ventricle, thin walls, as opposed to concentric hypertrophy, where because of the pressure, the wall gets bigger, the muscle gets bigger, but the lumen stays basically the same. Okay. Taken together, right? Heart rate max stays about the same, but stroke volume goes up. Then you can imagine that cardiac output is going to go up. And so that's all related to the Fick equation, right? So if cardiac output goes up because stroke volume goes up, then VO2 max is going to be able to go up. So most of our adaptations that drive the increase in VO2 are from heart rate going up, or from stroke volume going up, and from capillaries, mitochondria, and things making a VO2 difference go up. Okay? So that's where we're going to derive the majority of our adaptations. And on the very last slide, I had what's the time course of this? Well, VO2 max goes up almost immediately. That's the blood volume effect. Okay. Mitochondrial content, capillary content, arteriogenesis, those things are going to take several weeks. There's going to be a bit of a lag. But you're going to see a small increase, but the larger ones you're going to see marked increases within 3 weeks to a month or thereabout with your training. Okay. So it's a faster time course than increases in muscle size. So you'll see and feel improvements with aerobic training faster than you will if you lift weights. Okay. All right. That is it, everybody. You guys have safe travels. Have a nice break. Have a nice Thanksgiving. Be kind to one another. Give thanks for whatever you're thankful for.
I didn't